So I'm doing the medial elbow today, obviously, I would like to give some credit to Dr. Jay Smith and Dr. Rob Monaco, who some of the slides are theirs, and there may be other people's slides in here. We share slides quite a bit, but those two definitely have a decent amount of some slides that I'll be presenting today, especially some of the cases. So I wanted to give them credit for that. So I'll start with my case. This is Darren O'Day, who gave me permission to use his name and pictures and video of him. He's a 36-year-old Major League Baseball player who had 4 to 6 weeks of worsening medial elbow pain with pitching. So patient spent the entire previous year on the injured list of recovering from bilateral hamstring issues. One side, he had actually had surgery before he was traded to the Braves. And then after being traded to the Braves, he was having proximal hamstring problems on the other side. And we did a PRP, a successful PRP injection to the hamstring origin. So this is his following year. He was just trying to get back to pitching, and his spring training had just finished. The regular season was about to start. His pain was worse in that medial elbow with late cock and early acceleration. No moment of injury reported. He did report decreased control. He's not a power pitcher, but his control had been off, and he couldn't pitch anymore at his previous level. So this is some, oops, sorry, I don't need the video there. This is Darren pitching. You can see Darren's mechanics here, and he is kind of close to what you would call a submarine pitcher. You know, there's different kind of moments that people can pitch. You have your overarm pitchers, you have your kind of 3/4 arm pitchers, and you have your sidearm, which gets down to your submarine, which is kind of below, sidearm pitching. Interestingly, there's data looking at different kind of pitching styles, which I won't really get into in this talk, but the sidearm pitchers here and the submarine pitchers actually put more torque on their shoulder, and in theory, they put less torque on their elbow with the way they throw. But not a ton of data. But you can see Darren's pitching style. He's not a real fastball pitcher there, but he relies a lot on his control and his motion to create his pitches. So this is kind of hot off the press, as there's a new ultrasound manuscript coming out looking at what we need to assess in different regions for ultrasound, for sports ultrasound training, which a bunch of us are involved with. And so the medial elbow is not one of the more complex areas. Required is the common flexor tendon, the ulnar collateral ligament, including dynamic stress fuse, the humeral ulnar joint, and the ulnar nerve. So 4 structures, which are all fairly easy to see, which we're going to go through today. And then optional one are things like medial impingement and the medial cutaneous nerve of the forearm, if there's a clinical question that might need to be addressed. So let's start with the common flexor attachment. When you're assessing a common flexor attachment, as we know, the origin is on the medial side at the epicondyle. You want to always, get a smooth, bony contour, smooth, bony picture, and the common flexor origin, common flexor tendon attachment to that. It's relatively shorter and broader than the common extensor origin. And the key too for getting a really good image is to realize, you want to be angling here up towards the middle of the wrist here, not like along the side, which is the mistake a lot of people make. Anytime you take a picture, you want to take an orthogonal picture at 90 degrees. And so this is kind of a blown up image on a shorter footprint, showing a nice round fibular appearance of a common flexor tendon origin. So what kind of pathology do we see? Well, tendons are tendons, so we see a lot of the same things with tendons all over the body. Tendinosis, partial tearing, full tearing, and calcifications. So this is at the top showing kind of a partial tear of a common flexor tendon, but you can still see there's some tendon attached here. This is kind of a classic tendinopathy. You see thickening of the tendon, you see your hypoechoic changes, not really cortical irregularities in here. And then sometimes with more chronic injuries, you'll see some calcification within the tendon that can lead to shadow and distal to, or deep to the tendon as well. So as you assess these things, it's always important to realize we don't just want to take one picture. We want to kind of scan the whole width of the tendon, right? And so this is showing a tendon that has some thickening, some tendinopathy, as well as some partial tearing, which you can kind of see right in here. There's a dark kind of anechoic line in here. And then when you look at that in short axis, you can kind of see that same dark anechoic line. You can see the thickened tendon compared to that original picture I showed you all with some mixed echogenic signal in it. And then lastly, we turn on the power Doppler and we see a fairly decent amount of neovascularization within the tendon as well. Not diagnostic of tendinopathy, but it certainly helps point to some tendon issues going on potentially, and it is important when I'm going through my treatment algorithm. So not everything's a tendon injury. This is a case, the common flexor tendon is here, ulnar collateral ligament, we'll get to a second, is here, and this is the common flexor, the flexor pronator muscle mass. So you can see a kind of grade 2 tear slash strain through that muscle as well, as we scan it a little bit there too. And so make sure we're looking at the muscles in the surrounding area too. So how to get from the common flexor tendon to the ulnar collateral ligament. So I talk about this windshield wiper scanning technique. There's a few areas of the body where this can come into play. So basically, if you're scanning that common flexor tendon, as I was talking about before, you hook your proximal end of the probe, and then you just scan down inferiorly until you get to the ulnar collateral ligament, the anterior band of the UCL, which is the one we're interested in. So here's my common flexor origin. Now I'm starting to do that scanning technique as I'm just keeping this hooked here, and you can see at the end the ulnar collateral ligament kind of bridging across the area. So it's something y'all should work on if you're not used to going from one to the other, but you can go back and forth and get a good picture that way. Just make sure you kind of hook that proximal end on. So when we're looking at the medial collateral ligament complex, really the only real clinically meaningful one tends to be that anterior band of the ulnar collateral ligament. There is an oblique band and a posterior band. The posterior band I'll show you all as well, because you've probably seen it even if you didn't know it was there. But clinically speaking, this anterior band is the one where we seem to run into all the problems with our overhead athletes. So the probe position should be between 30 and 90 degrees. The arm position should be between 30 and 90 degrees. 70 degrees is somewhat preferred, but anywhere in that range works. I usually have them on their back, or you can have them on their side facing that arm to be a little bit more comfortable for them. And then you want to apply dynamic stress with at least 30 degrees of flexion of the arm. So statically speaking, this is kind of your picture. You see the anterior band of ulnar collateral ligament coming from the epitrochlear of the humerus to the coronary process of the subline tubercle of the ulna, and where it attaches there, crossing over the ulnar humeral joint. Dynamic assessment is super important here, and certainly takes a little bit of extra skill to keep the probe steady here. You can see dynamically the ulnar collateral ligament coming across the joint here. You can see some widening of the joint with some stress there, and you can see that there's still continuity of the ligament as we go across. So what are you looking for with pathology to the ulnar collateral ligament? So really you're looking to change it with stress views. So it's very rare, and I'll show you a full thickness tear of the ulnar collateral ligament. I don't want to say it's rare, but it's certainly not as common as seeing sprains or partial tears going on there. And so they talk about in certain papers, measuring the peak to peak distance. And so you see the peak here with the arrowhead and the peak here, and you can see it here as well. And so in this paper, this was 2.3 millimeters at rest, the peak to peak distance, and with stress put on, it was 6.3 millimeters. And so that's a 4 millimeter difference, which is highly significant. You can also see sometimes this is a little fat herniation as you apply the stress. After there's been a significant injury, there's a little fat pad that sits under that ulnar collateral ligament, which will sometimes herniate into the joint. So abnormal is greater than 2 millimeter difference between stress and rest, or greater than 1 millimeter versus the opposite side. And those are kind of general numbers. I'm going to go through a few studies here to show you that there's some variability in some of these numbers. This is one of my patients, and this is actually measuring right versus left side. So the symptomatic side, you can see with 7 millimeters of kind of gapping with stress, whereas our asymptomatic side was 3 millimeters. So 4 millimeters different side to side, highly significant for ulnar collateral ligament injury. Partial tears of UCL, as I said, are common. That's typically more what I look at in my office than complete tear, just because of my patient population, I guess. Dynamically speaking, once again, you can see the ligament kind of crossing over as we stress it. Look right up in here, you can see there's some tearing going through the central portion of the UCL. Probably a grade 2 injury. I don't think this is a complete injury. If you scan the whole ligament, you can see parts of it are attached. Same thing here. This is another kind of grade 2 UCL injury. You can see with stress, this hypoechoic kind of changes going on, and we kind of stress the ligament going across it. So both of these are kind of partial tears of the UCL. These are some static images of full thickness tears. Once again, these don't come in as often. You can see one here. There's a complete anechoic region where the ligament should be. And here you can see some ligament going across and then no real ligament here. But, you know, once again, for this, as well as a lot of ultrasound, it's really those dynamic images that are going to be able to discern sometimes these partial versus complete injuries. So a couple studies here. You know, Lev Nazarian has done a lot of the work in this area. This is a study. He used to go to training camps throughout Major League Baseball down in Florida, you know, back in the world, and we could actually do that kind of stuff. And, you know, he looked at 368 asymptomatic pitchers who did stress ultrasound over a 10-year period. This is a device that they used to and actually still use to really standardize how to do a stress or radiograph or ultrasound of the medial elbow. And so they put you in this device and they apply this set amount of pressure here. Some interesting studies from his findings. He found the dominant side ulnar collateral ligament was thicker than non-dominant side. Once again, these are asymptomatic Major League Baseball pitchers. He also found the ulnar humeral distance in the dominant side was greater than in the non-dominant side as well. So just from pitching, you can get a thicker ligament, right? That's the adaptation to pitching. You get a little bit of increased stress. That's not that peculiar, but it's important to note as we're examining these. He also found more calcifications in asymptomatic players than he did on their non-dominant side. He didn't have a lot of folks who had a UCL injury during the 10-year period, but there was not a correlation found with those who had a previous UCL injury, nothing that they could find structurally to kind of link the two. He also found that over the 10-year period, looking at the same picture from year to year, he actually found that there was some increased laxity that would occur just as they went on with their careers. So another interesting study that Lev Nazarian and his folks kind of put out too, looking at different age, youth athletes in different age groups. And so there's a few significant values here. The most important, I think, was looking at the mean joint space at rest. And so at rest, in a 12-year-old pitcher or a 12 to 14-year-old pitcher, there's significantly more laxity, up to, the average was 6.5 millimeters of laxity just at rest here. Whereas a 16-year-old pitcher, that ligament kind of tightens up, the growth plate is kind of fusing more, so there's less laxity there, only 4 millimeters on the average, both of which are probably higher than you see in adults still, but big difference side to side. So if you're looking at young athletes, obviously we see way more growth plate injuries in young athletes, apophysitis and growth plate avulsions, but the only humeral distance is going to be larger even in asymptomatic youth athletes. And then the last study here looks at 41 college and professional players being evaluated for ulnar collateral ligament injury with MRI and a dynamic ultrasound. They were trying to predict which players went on to needing surgery for the ulnar collateral ligament and which ones did okay with rehabilitation. And so they found the sonographic joint laxity showing the ring down artifact, and that's here. So when you stress the joint, you can get some air in the joint, and this air can create this kind of hyperechoic line and this kind of ring down artifact throughout the joint. So it's not that uncommon actually to see it. But in this study, they found the ring down artifact as well as tenderness with the stress ultrasound were more significantly or frequently found in the surgery group. And so those are things you want to look at, pain with dynamic sono palpation and dynamic sono testing, as well as this kind of ring down artifact inside the joint as well. And then UCL reconstruction, this is one of Jay Smith's pictures, but there's lots of techniques now that they do for ulnar collateral ligament reconstruction. This is kind of the classic one where you would take your, usually palmaris longus ligament and do this kind of double loop over here. Nowadays they're starting to do more ulnar collateral ligament repaired actually, as opposed to reconstructions, but still reconstruction is the most common thing you'll see. A couple of things to note if you're looking at ultrasound post UCL reconstruction. First of all, it's very important to note the type of reconstruction that was done so you know what to look for. You can see this, they have two separate bands as the picture kind of shows here. And so that's not a tear, that's not pathology, that's normal. And then as they hook this in, right, this is your sublime tubercle here. Usually they're going to dig in a little bit distal to that because you have a little bit more purchase here, so you want to look out for that. And so this is showing kind of just a dynamic or views of the different bands of the reconstructed ulnar collateral ligament. Things aren't going to change. I mean, there's going to be maybe a little more laxity with stress. Usually when you're asked to evaluate these, it's going to be more just looking at continuity of the graft. And so, just make sure we know what we're looking for, and you can get some really good pictures of post UCL reconstruction. So moving on from the UCL to the ulnar nerve in the cubital tunnel. So we want to measure the nerve in short axis in the cubital tunnel. The cubital tunnel is just past the area where the medial epicondyle kind of bridges it. And you can see kind of where we're looking here. Here's the ulnar nerve in short axis. Here's your, excuse me, osmolar fascia or osmolar retinaculum on the top. And then the floor is the posterior band of the UCL. And so you'll see this kind of nice ligament going across the bottom a lot. And just so you know what it is, like I said, clinically, doesn't seem to be very much involved in pathology there. And then you have your two heads of your FCU, which are gonna come over to the top at some point. And your ulnar nerve will pierce those two heads. So once again, another dynamic video here. You can see we're looking at the medial epicondyle with osmolar fascia. As we go a little bit more distal, we're going to get in between the two heads of the FCU, and we're going to scan kind of distal to proximal, and you can kind of see the fascia there connecting the two heads and the ulnar nerve deep to that. Another picture going a little bit further down, so keep going distally, and you can see the ulnar nerve come out a little bit more distal as we get the two heads of the FCU coming over the top. The conspicuity of the nerve actually increases as we kind of get closer to the muscles. But it's always good to kind of scan, until that's usually kind of where I stop scanning when I'm going distally along that medial epicondyle. Long axis, it can be tough to get a nice long axis view of the tendon because it kind of has a tortuous course as it goes behind the medial epicondyle. We're looking for changes in diameter. We're looking for things we look at for any nerve. We're looking for proximal thickening and distal tapering, and what we call notching of the nerve, where there may be a moment of entrapment there. So as far as pathology of the cubital tunnel, it's the second most common nerve entrapment of the upper extremity after the median nerve. 23% of folks will have an anomalous Cutaneous epitrochlear area. So you can see that in this picture here. So if you are in the cubital tunnel or you are deep to the medial epicondyle, if you see a muscle above the nerve, that's an Cutaneous epitrochlear area. So there should never be a muscle above the nerve. Don't confuse it with the medial head, the triceps, which will sit next to the nerve, which can sometimes be a little bit confusing. So you look at the cross-sectional area of the nerve, greater than 10 millimeters, it tends to be kind of abnormal. You can look for other things that may occur in here, such as bone spurs or osteophytes. Once again, you can look for notching, like we talked about, changing the diameter of the nerve. So, obviously the thickening of the nerve, the loss of fascicles as we scan down is a classic sign of a nerve entrapment. You can see a really big nerve here as we go from proximal to distal through the cubital tunnel, and then it normalizes. Also, you can see how oops, let me go back again. Also, to show that one more time, you can see the fascicles, how you lose that kind of honeycomb appearance of the nerve at the site of entrapment. Then dynamic nerve scanning, right? So we want to look for any kind of instability of the nerve. And so we're going to start this video here. And as we kind of scan up really slowly, you'll see normally that nerve will kind of stay up in this area and it won't go over the top of the medial epicondyle. It's really not uncommon. 18% of asymptomatic individuals will have some subluxing of the nerve. So we'll show that in this video here. So same thing, we're kind of going into the slow flexion, work on keeping that probe with the nerve and the medial epicondyle in the same view, and you'll often feel this little click as the nerve kind of goes over the top right there. So this is a patient of mine who had one side, she had some snapping on one side, which is asymptomatic. She'd had it her whole life. The other side, she had a more painful snapping. which cause nerve symptoms. And so you can see the two nerves here, asymptomatic side, symptomatic side is larger on her symptomatic side. And as we test her dynamically on her asymptomatic side, you can see her nerve kind of coming over the top here. She has subluxated ulnar nerve. Once again, it was asymptomatic. As we look at her other side dynamically, she had a subluxated nerve, but she had this kind of double snap that occurred at her medial head of the triceps. It was kind of pushing that ulnar nerve out of the groove. So remember, you can get a snapping medial head of the triceps with that ulnar nerve, which can be more problematic than just a subluxated nerve, which is fairly common to see. This is a case of someone who had a medial epicondyle bone spur here, right? You can see this little prominent spur here, and you can see that over time, this spur had probably caused this ulnar nerve to kind of split into two. And if you look at the video, you can kind of see that nerve kind of impaling on the this little spur here as it goes over the top right there. And so it's subluxating, but because of this osteophyte here, getting symptomatic at the time. And so lots of things you can see dynamically that you wouldn't be able to see on the static MRI or other images of the area. And then this is a case of a snapping that's somewhat peculiar here. So you can see with elbow flexion here, here's the ulnar nerve, but then this is what's snapping, right? Let's see that again. Over the top of the ulnar nerve, right? So it's not the nerve snapping over. This is actually snapping of the medial antebrachial cutaneous nerve, and that's a bigger nerve than you would typically see as well. So there's thickening of that medial antebrachial cutaneous nerve. And so this is the nerve that people don't look for, but it's probably seen you even if you haven't seen it. And so just to kind of refresh your anatomy, this comes off of the medial cord of the brachial plexus here, directly off of plexus. The medial brachial and the medial antebrachial cutaneous come off of it. The easiest place to find the nerve is not actually there, but as you on the elbow, just proximal to it. If you follow the basilic vein, it usually runs right next to it, between the vein and the brachial artery. So that's usually your landmarks, and then the nerve actually splits into kind of more of an anterior and posterior branch, and often does this little nutcracker effect over the vein, which I'm going to show you in a minute. This is an anatomic picture. Same thing. Here's the MAC right here, median nerve, brachial artery, brachial vein. Basilic vein right here, ulnar nerve. You can sometimes see all these in the same picture, such as here. So you can see that MAC between the vein and the artery here, with the medial nerve being somewhat under it or off to the side of it. So I mentioned it kind of comes over the top a lot. And so this is where you probably will see your pathology of your MAC with some kind of venipuncture. And so as we scan more distally, you can see that nerve coming right over the top here of the brachial, of the basilic vein right here, right over the top, right? So if someone's going to be given blood, this is where you might see an injury to the nerve in that area. And the other thing to note, this is the same patient here. This is the MAC nerve right after it kind of came over the top. And I just wanted to show this is medial epicondyle here. And so it doesn't come super close to medial epicondyle, but depending on where you're putting your needle in for procedures, we should be aware of the MAC's kind of relationship to that area. So lastly, posterior medial elbow impingement with valgus extension overload. Boy, I didn't have any good videos or pictures, and I had a hard time finding. This isn't reported very much, but it's really not hard to look at this with ultrasound. So, back in the back of the elbow here, you can see some posterior medial osteophytes that are present. You can see that on the CT scan. Even on the X-ray, you get that little perching here on the back area. But ultrasound is a great way to look at this dynamically. And so this was an article or a paper I found online. As you go from elbow flexion to elbow extension, you can see this osteophyte kind of pinching. Sometimes it'll pinch the fat pad back here. Sometimes you'll see it pinching the bone. You'll see some cortical irregularities here as well. And sometimes you can see some neovessels and other pathology too. And so it's a good way to look at posterior medial impingement dynamically and kind of see what's going on in the back of the joint. All right, so back to Darren's case here. So Major League Baseball pitcher, before he even stepped foot in my office, he had a MRI done. This MRI was initially kind of read as having a possible full thickness tear of the ulnar collateral ligament here. You can see the ligament coming down proximally. It's hard to say what's kind of going on here at the proximal area, but it certainly doesn't look normal. So that was concerning. So they sent him to me to do an ultrasound and kind of make a game plan for him. And so statically, you can see his ulnar collateral ligament look pretty good. These are both his pictures here. Proximally, it looks a little bit, and usually you can get a very little anisotropy here. And so there was some definitely differences on the proximal end of that ulnar collateral ligament, consistent with what the MRI showed. And then dynamically speaking, as you stress this area, you can see some hypoechoic changes proximally, but no full thickness tear noted. His ligament was connected and pulling on both sides, as you can kind of see. There was no pathologic widening that we saw along the ulnar humeral joint. So this was Darren's report of his elbow. So, you know, the way I do my report is I kind of talk about all the landmarks I would looked at in the scan. Obviously, I say pictures of it. And the way I read this was a partial thickness tear, irregularity of the proximal ulnar collateral ligament with no full thickness tear noted. And there are 2 millimeters of ulnar humeral widening with stress to the area. And the rest of his medial elbow examination was intact. And so for a, you know, this would be billed as a complete ultrasound evaluation because we looked at all the structures on the medial side of the elbow. So the outcome of the case with Darren is that we did decide to inject him with a leukocyte poor PRP into the UCL and ultrasound guidance. I also, as I often do, will pepper the common flexor attachment with a little bit of PRP as well. We shut him after 6 weeks, and we followed the PRP injection. You know, it's kind of tough when the season's starting, but he had some friends too who had been through this, and they tried to push them back at 3 to 4 weeks, and they failed. So we were really adamant about 6 weeks, and we do a lot of BFR with our Braves players, and we find it to be very helpful from a rehab point of view. And so I just wanted to kind of make mention of that. We did that early on in his rehab, and he felt really good at the 7-week mark when he started his throwing program. He did have a setback, just to point out, at that 9 to 10 week mark. And we just kind of, you know, as you're supposed to do with the interval throwing program, we kind of shut him down for a week and let that kind of calm down. And then he started a throwing program again and never had another ounce of pain. And, you know, returned to Major League Baseball last season. He pitched for us in the playoffs, and he's been pitching again this year without any additional problems. And that's the end of my talk. Thank you.
And that was that was fantastic.
Sharon.
Any specific questions for Ken?
So I guess time for any questions.
Just a couple. I have a couple comments, especially for those of you that are new to the elbow.
I guess you can chat them, or you can unmute and say them out loud. I'm happy to answer anything.
Hi, Dr. Mautner. This is Sai from Dallas Fort Worth. I had a question regarding the use of PRP in ulnar collateral ligament treatment. Is there a specific reason you use like leukocyte poor PRP versus leukocyte rich? Thank you.
Yeah, you know, I was muted, so I caught the second half of your question, but I think you were asking about leukocyte poor versus leukocyte rich PRP. And so the answer is, yeah. So I know if you look at the data for a lot of the soft tissue problems out there, like, you know, lateral epicondylosis and the glute medius study that's out there, they use the leukocyte rich PRP product, and the data said leukocyte rich is better for these tendon issues. But my experience, and actually not my experience, but if you look at the basic science data, actually leukocytes tend to not, PRP preparation with leukocyte tend to not do as well as PRP preparation without leukocytes. So in terms of tenocyte production and healing of tendons, it seems that the leukocytes are adversely affect the healing. And so I don't know how much that plays a role, but I do a PRP product that has a high platelet count below leukocyte count, specifically neutrophil count. And that's always been my go-to. And so I'm not recommending like an ACP type product that has low platelets and low leukocytes. I'm recommending kind of the double spin method where you're getting a higher platelet count and a lower leukocyte count, specifically neutrophils. Also in a high level athlete or someone who you're trying to get better quicker, if I can mitigate any of that inflammatory response, I think that might be helpful to him as well.
This is Doug. I had a couple of comments. Again, Ken, this was awesome. Everybody has a little different protocol. I generally start my elbow protocol anteriorly looking at the joint. The ulnar humeral joint is just another look at it. I also look at the radiocapitellar joint and for degenerative changes. If you're, if people here are just getting started with this, again, a couple tips. One is, Ken made those videos look really easy. And it's important to be able to, get proficient in these videos. And then I use the videos to take my measurements just by scrolling back on the machine and then measuring the widest point and not. Also, if you're new to the ulnar collateral ligament, the anterior band, there's actually two bands to the ulnar collateral ligament, an anterior posterior band. And so you can see those two bands, and just something to be aware of and not misconstrue it for a small longitudinal pair. So those are the only comments I have. But again, this was really fantastic, Ken.
Hey, this is Mederic. Again, great job, Ken. Thanks for joining us this morning. One of the things we're trying to highlight with this series is just, how people will report their findings as well. And so for those of you who joined us for some of our other talks, you can kind of see we all do this a little bit differently. And so, Ken actually then described his whole exam, and how he was obtaining images and going through, which is a bit different. I kind of had a checklist sort of thing that I commented on and didn't really go into the nuances of the positioning and such. So there's a lot of different ways that you can do this. So I think it's helpful to see how other people do this so you can kind of figure out what works the best. But the key points is, we're mentioning all the components of the exam, all the structures that were evaluated. And that's going to be important from a billing perspective. If you're billing a complete exam, obviously you want to kind of make note that you evaluated and looked at all the structures on the checklist. And so there's several different ways to do that. And I think it's great to be able to see the variety there.
Hey, Ken, it's Jay. Good morning, everyone. So great job. I just, the comment that Doug made about this being the dynamic part of these exams being a little bit challenging. One of the tricks that you can use if you're struggling or you're new to it is the snaps, the medial head of the triceps, the antebrachial cutaneous nerve, and the ulnar nerve. It's always great if you can see it move over while you're flexing, but don't hesitate to take the transducer off and flex the elbow and let it go and then catch it on the way back. Sometimes we always want to see it move, but you could always flex the elbow, let it dislocate or subluxate or whatever it's going to do, then put the transducer on. And with a little bit of transducer pressure, you can actually accentuate it. Of course, being careful not to hurt the patient, right? Because if they got ulnar neuritis, it'll bother them. But even in the medial antebrachial cutaneous snap that you saw Ken show, sometimes it's actually more prominent coming back. And surgeons that do that look at this clinically in the elbow, they'll do the same thing. They'll actually subluxate it and they'll get their thumb behind it and try to trap it in the dislocated or subluxated position and then catch it on the way back. So it's just a nice trick to do if you're struggling.
Great point, Jay. Thank you.
Ken, one other question, whenever you're looking at some of your throwers and their UCLs, I know that historically a lot of folks had looked at the UCL stress at 30, and some newer studies are talking about looking at a more functional position, up at maybe at 90 at more of a traditional throwing. Now with your pitcher, it might even be different, right? Because of his technique. But can you maybe comment on how you use various angles to look at stress at the UCL?
Yeah, I mean, just like your milking maneuver, when you're kind of stressing them through the range, you'll kind of find pitchers might have different pains at different levels of that kind of wave sign or milking maneuver that you do there. So I tend to kind of go for the areas where they're kind of symptomatic the most, right? Because that seems to be the easiest thing to do. But yeah, to Derek's point, don't be afraid to kind of look at some different angles, because things may change, dynamically or not. Now, usually you're not going to get a partial tear to turn into a full tear. But it's always good to try to reproduce their symptoms as you're doing these kind of maneuvers. And then you kind of know that you're probably at the right angle for that to occur. So it's a good point to make. And the other point I didn't make too, and especially in that post UCL reconstruction, is that I didn't mention this, but once they've had the surgery as well, some surgeons still traditionally always kind of transpose the ulnar nerve. I didn't show any videos of transposed ulnar nerves, but sometimes those ulnar nerves, they transpose them, anteriorly to get them out of the way, because people with chronic UCL stuff will often have some ulnar nerve symptoms as well. Dr. Andrews famously will transpose all the ulnar nerves. I don't think he should stop doing that. So that's something else to be aware of, especially if you're going to be considering doing procedures post UCL reconstruction, such as PRP.
All right. Well, Ken, again, thank you very much. And just a reminder, September 11th, we're going to have the posterior knee by Dr. Blake Bogus. So everybody have a good Friday and a good weekend.
Thanks, guys.